Let us study about spinothalamic tracts in this video, which are commonly called as ventrolateral pathway. It is debated for long whether to consider this fiber bundle as two separate tracts made up of lateral spinothalamic and anterior spinothalamic tracts, or whether to consider this as a single structural and functional continuum known as ventrolateral system. Either way, it carries pain, temperature, non-discriminative touch and pressure sensations to thalamus. If you break this fiber bundle into two groups, then the fibers in lateral spinothalamic tract carry the pain and temperature modalities, whereas fibers in the anterior spinothalamic tract carry the coarse touch and pressure modalities. The ventrolateral system does two important functions. One, it carries pain sensations, which is an interesting sensation whether you look at it from patient's perspective or from the physician's perspective. Secondly, it carries coarse touch and pressure, an alternative route for these modalities to the dorsal column. Receptors for touch, pressure and temperature are the mechanoreceptors or thermoreceptors, whereas receptors for the pain are the free nerve endings or the nociceptors. Let us see the beginning of spinothalamic tracts. The A beta fibers carry the coarse touch and pressure sensations, whereas A delta and C fibers carry the pain and temperature sensations. All these fibers have their first order neurons in the dorsal root ganglion. The A delta and C fibers, because they are of smaller caliber, they enter the spinal cord through the lateral stream of dorsal root. Once they reach the spinal cord, they divide into ascending and descending branches and travel in tract of Lissor for a few segments upwards or a few segments downwards. Let us see how the anterior spinothalamic tract begins. It is shown in the lower section here. Once the primary afferent reaches the gray matter of the spinal cord, it relays by synapsing with the second order neuron present there. Axon of this second order neuron first ascends on the same side for a few segments. Then it crosses to the opposite side ventral funiculus and then again ascend as anterior spinothalamic tract. If you look at the lateral spinothalamic tract, which is shown in the middle section here, once the primary afferent reaches the gray matter of the spinal cord at the appropriate level, it relays there by synapsing with the neuron, which is a second order neuron, and the axon of this second order neuron now crosses within the same segment to the opposite side lateral funiculus and ascends as lateral spinothalamic tract. So anterior spinothalamic tract first ascend on the same side, then cross and then ascend as the anterior spinothalamic tract, whereas lateral spinothalamic tract immediately crosses and ascend as the lateral spinothalamic tract. Both these fiber bundles cross in the anterior white commissure. Let us see where these neurons are located within the spinal cord gray matter. The fibers which contribute to the formation of spinothalamic tract, they are located in lamina 1, 4, 5, 6 and few also in the lamina 7 and 8. These are grouped into three separate groups. Those neurons which are located in the lamina 1, they form the apical dorsal group. They predominantly receive noxious stimuli, mainly from skin, also from deep somatic and visceral structures. They have relatively small receptive fields and these fibers project to ventral posterolateral nucleus of the thalamus. The neurons which are located in lamina 4, 5 and 6, they form the deep dorsal group. They receive both innocuous as well as noxious sensations. Again, the sensory fibers arrive from skin as well as deep somatic and visceral structures, but more from deep somatic and visceral structures. They have relatively larger, that is medium-sized to large-sized receptive fields. They either project to ventral posterolateral nucleus or to the centrolateral nucleus. The neurons in lamina 7 and 8, they form the ventral gray group. Again, they receive both innocuous and noxious stimuli, but they receive input predominantly from deep somatic and visceral structures and very few fibers coming from the skin. These cells have relatively large and complex receptive fields, some of them having even bilateral representation, and they project to intralaminar or the medial thalamus nuclei. So in the thalamus, if the spinothalamic tract fibers are projecting to ventral posterolateral nucleus, from here the fibers are projected to primary somatosensory cortex, and this forms the neospinothalamic pathway. And these fibers are concerned with discriminative aspect of pain perception. Those fibers which project to other thalamic nuclei, like the intralaminar or medial thalamic nuclei, from there they project to cingulate cortex, insula or limbic lobe. They form the paleothalamic pathway, and they are concerned with the arousal and aversive behavior associated with pain. Let us see the somatotopy of the fibers of spinothalamic tract fibers in the fiber bundle. At each level, as the fibers enter the tract, they displace the lower level fibers outwards. So if you see at the level of cervical spinal cord, then the outermost fibers are the sacral, followed by lumbar, thoracic, and the innermost fibers are the cervical. So represented by the somatotopy, which shows sacral fibers laterally or outwards and cervical fibers inwards. Let us see the location of this spinothalamic tract, starting from spinal cord all the way at different levels of brainstem. So in the spinal cord, this tract extends both in lateral as well as ventral funiculus. In the lateral funiculus, it is medial to the ventral spinocerebellar tract, and in the anterior funiculus, it is immediately behind the vestibulospinal tract. So the portion in the lateral part can be considered as lateral spinothalamic tract, and portion in the anterior funiculus can be considered as anterior spinothalamic tract. These tract fibers are also intermixed with the fibers of spinotectal tract and spinoreticular tract. In case of the lower medulla, that is medulla at the pyramidal decussation level, these tracts are found in the tegmental region, lying in the lateral aspect along with other ascending tracts. At a higher level of medulla, that is at the level of sensory decussation, again both lateral and anterior spinothalamic tracts are found in the tegmental region in the lateral aspect along with other ascending tracts. When we reach the open medulla, that is the upper half of the medulla oblongata, there is what is called as modality segregation. Here, the touch and pressure sensation carrying fibers of the anterior spinothalamic tract merge with the medial lemniscus, which is also carrying similar modalities, and the lateral spinothalamic tract fibers, which are carrying the pain and temperature sensation, will hereafter be known as spinal lemniscus. So now the anterior and lateral spinothalamic tract fibers get segregated into medial lemniscus and spinal lemniscus. The same lemnisci will be seen forming a band of lemniscus in the lower pons. In addition, we can also see trigeminal lemniscus here, and this is a somatotopy where the cervical fibers are medial and sacral fibers are lateral, whether it is for the touch and pressure fibers or for the pain fibers in the spinal lemniscus. Upper pons shows the same feature of band of lemniscus. An additional lemniscus here is the lateral lemniscus, which is added up. In case of midbrain at the level of inferior colliculi, the same four lemnisci are found, but their arrangement is not from medial to lateral. Instead, they are arranged ventrolaterally. When you go further higher up at the level of superior colliculus, the midbrain shows one major change, that is the lateral lemnisci will have disappeared here, will not be present here, because those fibers in the lateral lemniscus will have relayed in the inferior colliculus. But the other three lemnisci are found, and the somatotopy in case of medial lemniscus is cervical fibers medial and sacral fibers lateral. In case of spinal lemniscus, there is a slight rotation. Cervical fibers, they are slightly ventromedial, and the sacral fibers are dorsolateral. So as we saw, the pain and temperature sensation fibers in the lateral spinothalamic tract, they relay in the second order neuron in the gray matter of spinal cord. The axons of these fibers cross at the same segment, continue high up as the contralateral lateral spinothalamic tract in the spinal cord, and continues as spinal lemniscus in the brainstem. The coarse touch and pressure fibers They again relay in the grey matter of the spinal cord. These fibers first ascend a few segments, then cross and ascend as anterior spinothalamic tract in the spinal cord, and they join with the medial lemniscus in the brainstem. Once these fibers reach thalamus, they relay in the ventral posterolateral nucleus, or they may relay in the centrolateral or other intralaminar nuclei. The fibers from ventral posterolateral nuclei will pass through the internal capsule and reach the primary somatosensory area or area 312. The fibers which are reaching other nuclei of the thalamus will be reaching other parts of the cerebral cortex. So what's the clinical implication? If there is a patient who shows loss of pain sensation on one side of the body and loss of discriminative touch on the opposite side of the body, most likely the lesion will be in the spinal cord, because in spinal cord the fibers in the spinothalamic tracts, whether it is anterior or lateral, they are already crossed, whereas the fibers in the dorsal column fibers, they are ipsilateral. But if you find a patient having both loss of pain sensation and discriminative touch sensation on the same side, then the lesion is most likely at the level which is above the level of sensory decussation of medulla, because there both will be having contralateral sensation. Any one side, that is right side fibers, will be carrying the information from left or vice versa. The second point to be remembered is we do chordotomy or ablation of the spinothalamic tract electrolytically, and this is done to alleviate chronic pain, especially when the pain is associated with carcinoma, that is a terminal pain, and this will give rise to relief of pain for about a year or so. But this is not a permanent relief, because by the end of 1 year, the fibers on the ipsilateral side which are traveling through the spino-reticular tract or traveling along with the dorsal column, they take over and the pain returns. So usually this chordotomy is done only in those patients who are terminally ill and having chronic intractable pain. Thank you very much. Hope you enjoyed this video. You can visit this site for other such videos.